Hello, I'm Hunter Schultz, and this is Winning Healthcare Food Fights Without the Mess. My guest today is a lawyer, CEO, entrepreneur, and has extensive healthcare experience, from helping start a foundation dedicated to accelerating the way we discover cancer cures, to owning a company that operated state-of-the-art, comprehensive outpatient rehabilitation facilities. He's a longtime friend, too, and he joins me today to share his view on what's going on with today's system and address one of the frustrations physicians are feeling right now and heightened by COVID-19. They want out of the system, but are facing legal non-compete clauses. If you're one of those physicians, stick around. There may be some hope for you starting right now. Welcome to the show, Glenn Nadell.
Thank you for having me.
Well, it's certainly a pleasure, and you know there are many small coincidences in this world, and as it turns out, long ago my dad died of multiple myeloma, and it turns out you ran a foundation which was dedicated to accelerating the way we discover cures, including multiple myeloma. So you're familiar with that. But I also appreciated one thing I always tell people when I describe you, it's your way of, your legal mindset of fighting without fighting. At least that was my perception of it. It seems opposite to the perception that lawyers love getting into a fight. But how would you describe that?
Well, I certainly don't disagree with the manner in which you described it. What I try and do, which is one of my bedrocks and principles that I guide not just my legal practice on, but my life, is I always try and put myself in the position of the person I'm either speaking with, an adversarial lawyer on the other side of the table, a client. And I found that if I can understand what's important to them by being in their shoes, that can enable us to come to a transaction that's completed, that both parties can move forward on a congenial basis, or alternatively, understand what's important to them. So, for example, if I am able to uncover by doing that there's something that they really need to make this transaction go forward, and if hypothetically it's not really a big deal to my client, I can leverage that and give that up to get something that's much more meaningful to me in return, which the opposing counsel may or may not be interested in. But even if he is interested in it, he may not give it up readily, but when he gets what he or she wants, then we're able to move forward. And also, I guess the other side, too, is not being a litigator, although I've been involved in litigation over the years. I just find that that's a better way to move forward, and it gets a lot of things accomplished.
Funny how that works.
Yeah.
At Goldman Philanthropic Partnerships, you were looking for innovative cancer cures by funding, if I recall, researchers who otherwise couldn't get any funding. And
exactly.
I'd love to hear you unpack that a bit, because I just had a guest on a couple weeks ago by the name of Candace Lerman, who is a rare disease patient. And she's an attorney down in Florida, young attorney who is working to get funding and to get approvals for repurposing old drugs, kind of in the news with old drugs right now with COVID. But what are some of the roadblocks? What was that like?
Well, it's interesting you hit on something which I'll expand upon in a moment. But our goal was, with our scientific body of researchers that were our advisors, is we wanted to find young researchers, generally speaking, or older research who were looking at a way to cure cancer that either was frowned upon or just put off to the wayside because they didn't think it had any merit. So we were willing to risk our capital because it was our money, and we funded this research. And ironically, the first person we funded was Dr. Vincent Rajkumar of the Mayo Clinic, and he was a multiple myeloma researcher, and he was the one that discovered thalidomide, which was a drug used for other purposes, was somewhat effective in curing and at least reducing the impact of multiple myeloma. Ironically, since we were the first person that funded him and nobody would take a chance on him, he has since become a star of researchers in multiple myeloma. And it's kind of an interesting side story to show you what kind of wonderful man he is. About 15 years after we funded him, I needed a favor at the Mayo Clinic for a friend of mine. So the people I used to deal with at the Mayo Clinic were the CEO and some of the very senior people. Over time, they either retired or moved on. So I called Vincent. So as I get on the phone, he picks up the phone immediately, and I start explaining who I am on the theory that he probably forgot about me. He then goes into a long time of explaining how, but for what we did and the risk we took, he wouldn't be where he is. And you can certainly go online and look at the many papers and the research things that he's done. And he is a star today in multiple myeloma research, gets grants literally from all over the world. But for us taking a risk on him when nobody else would fund him, all this research, and again, like you said, getting an old drug to apply to a new type of, disease, which is exactly one of his research papers. It's exactly what he was able to accomplish. So we felt very good about that. And of course, when I talked to him and he started saying all the great things we did, I said, now, Vincent, please understand, I'm not going to be writing you a check on this phone call. And he started laughing. But we wrote him a check for $500,000 and he did some great research. And, everything has worked out wonderful for him and for people that have afflicted multiple myeloma like your late father.
Yeah. What was it that you were looking for when these people would come to you, or did they come to you or did you seek them out?
A little bit of both. What happened is we put on a symposium at the Mayo Clinic in Florida for 4 days, as I recall, and one of the presentations that I gave is with all these researchers, and we invited, cancer researchers from all over the country, maybe all over the world. I challenged them to submit to me ideas that they felt had merit and could possibly lead to a cure or maybe an amelioration of cancer, and that nobody else would fund. And I said, it was on, it was really kind of around the internet stage, but, we handed out either a one-page or they could do it online, but it was literally a one-page summation. It wasn't like looking at an NIH grant that, takes grant writers and takes them hours and hours and takes them all this time. We streamlined the process. We got all these one-pagers, and then we sat around with me and the founder and his wife, and we decided which ones we were interested in. And before we would fund it, because it was our money, we would basically sit down with our scientific group of researchers to get their input, which was advisory and not binding, because we didn't want their prejudices of a way cancer should be researched based on the cancer research protocols at the time to influence what we wanted to do. So that's basically what happened, and they loved the idea of a one-page submission. That's all it was. It wasn't some long grant application that would take them half their lives to complete.
And a waste of time.
Yeah, and we obviously, you could imagine how many submissions we got and how thrilled we were. And I will say this, nobody really then came up to us during some of the more social hours, et cetera, and tried to lobby, et cetera. It was more me going up to them and saying, could you give me a little more explanation why you think this may work or why you're thinking out of the box? So we had more information. But they were, believe me, you can't imagine how enthused they were to have such a streamlined ability to get their research funded, not go through all the protocols, et cetera, and at the same time get research funded that they felt had some merit, but nobody would take a chance.
It seems like that process of being able to sum it up in one page, which if you've been in venture capital, I've talked to a number of VC folks, and they tell you basically 1 or 2 pages, that's it. That's all I want to see. That's all I have time for. If you send me 100 page or 70 pages, I'm not going to read it. Sorry, but it's good to have that kind of walking through the door for your next, so they know you've done your homework. But it's one page that really makes that forces them to think. It forces them to really focus on what's important. What is it that you need to know? And so that was actually very good thinking on your part. So,
well, and we also funded Dr. Jim Gordon, who was the chairman of the White House Commission. Similarly, he didn't fill out a one page. We spent many hours with him, like we also did with Dr. Heimlich, and we got to learn about what he did, and then we more or less pick and chose a program that we felt was appropriate. And then we move forward. He didn't have to do a one pager because we spent so much time with him. But that's the benefit of when it's your foundation It's your money, although we raised outside money too, and we can decide how to allocate our capital. No different than a venture capitalist or anybody else that allocates capital.
Yeah. So you work with Dr. Heimlich, the Heimlich Maneuver.
Yes.
Was that before or after the Heimlich Maneuver?
Oh, long. This was 1999 to 2001, and the Heimlich Maneuver first appeared in an article written by Hank in 1974.
Wow.
Yeah, and it's also interesting because the maneuver wasn't accepted right out of the gate. So, for example, from 1976 to 1985, the American Heart Association, American Red Cross, they had a more traditional pound them on the back 5 times. That was the first way to stop somebody from choking. And if that didn't work, then you could go to what we call it the Heimlich Maneuver. They called it a pelvic thrust. And then because the Heimlich Maneuver was working so well, and I'll get into that in a minute, from 1986 to 2005, that was the number one technique to stop somebody from choking. And then to show you the politics of what happened, somewhere in 2006, the American Red Cross went back to the old method first and the Heimlich method second. And a lot of people have asked, how did the Heimlich Maneuver get so popular? And it's actually a very simple answer. And I actually remember we used to go to Hank's house in Cincinnati. And as an aside, his wife Jane has written a couple of books, one entitled What Your Doctor Won't Tell You, and it basically talks about alternative medicine at the time. It was written in 1990. But, I asked him, I said, how did it get to be so popular, et cetera? It was simple. It worked. It got a lot of favorable press long before we had social media and the internet. And when you go into Hank's office, you see every time the Heimlich Maneuver is mentioned in a Charlie Brown comic strip or the New York Times, anywhere in between, somebody would send him something and he'd frame it. And he had all these things where it was mentioned in movies and all kinds of things. But because it worked and it was fairly simplistic that people could just learn it very quickly, that's how it became popular. And that's why it works. And I think as we get into your DBC model later, that works too. And a lot of times, oftentimes you find things that work tend to buck the establishment, but at the end of the day, can and more likely will win out.
It's fine. I'm thinking of 2 things, 2 movies. Mrs. Doubtfire had the Heimlich Maneuver in it, and also Hitch had at the very end. They showed someone doing the Heimlich Maneuver.
Really?
Yeah, exactly. And there's a little trivia note. Don't ask me how I remember this, but Anson Williams, who was an actor, and he played Potsy on Happy Days. He was Dr. Heimlich's nephew.
I did not know that.
Every show, you learn something new. I learned something new on every show. So now you also owned and you managed, operated state-of-the-art, what would you call, comprehensive outpatient rehabilitation centers?
Yes, specialized in respiratory therapy for COPD patients.
And more than one.
Oh, yeah. We had them in, I think, about 10 states.
Wow. Well, you have some incredibly unique and valuable perspectives on this system and how it works. What were some of the roadblocks back then? What were you dealing with? Because that wasn't that long. Was it 20 years ago or so? Or what?
It was exactly. It was early 2000. It was basically 2000 to 2003. We saw a need for respiratory therapy, and what we did, which we were really ahead of our time, we built these centers near the largest respiratory therapy physicians in the country, the largest practice groups. And they were state-of-the-art. And remember, in 2000, what we did is, in order to make our respiratory therapists more efficient, we had carts with wheels. We had laptops that were wireless, hooked into our Wi-Fi. And we developed a program/software that was in lieu of the therapist taking notes. So as they were performing the therapy, they could spend more time with the patient, click on their computer, or drop-down screen would come, and whatever particular modality they did at that point in time, they would just highlight it, put their cursor on it, and it would be their notes. So at the end of a therapy session, which they would take 45 minutes, instead of them spending 15 to 20 minutes writing up their notes, which, to be perfectly candid, they disliked because they weren't giving the patient care that they wanted. They were just writing notes because they had to. As soon as that patient walked out there, they hit a send button, and their notes were beautifully typed on a beautiful form, ready to be submitted to Medicare. And that enabled them to be more productive. They got to see more patients. And for them, it's a win-win because they didn't have to do the part of the practice they disliked, writing up their notes. They got to spend time with patients, which is the gratification. The patients loved it because they give the patients more one-on-one care without worrying about taking notes, etc. And from a business perspective, it increased their productivity. They got more billable hours, if you will, in a day than other therapists. So it was a very profitable model. And we utilized the Medicare-based model because most people that have COPD are north of 65. Medicare complemented our billing system and our notes on more than one occasion. They said they never saw anything like that. So as I'm telling you this, you're probably thinking, well, how come we don't see 100 of these centers today? The reason was, one day I come in the office, I was the president and chief operating officer, and I get a notice from Medicare. They were reducing our reimbursement, not just us, but anybody that did this particular therapy, by 50% overnight. No reason given, no notice. That's what they were doing. So we called a group together of, all the corporate people, and I said, here's what we're going to do. We're not going to open up any more new facilities. It's not economically feasible for our investors. We will instead continue taking new patients, continue the good care with the old patients until our leases run out. When our leases run out in the facilities, we'll just close up shop. That way, the therapists know how much longer they'll be employed. The patients will know how much longer we'll be there. But we can't operate at a loss. So the lesson I learned from that was very simple. Never go into a business, never run a business, never operate a business that the government controls your pricing. Let the free market control your pricing. And years later, and I mean probably 15 years later, a number of my clients wanted to buy ethanol plants because you could buy them at that point in time for 20 to 30 cents on a dollar. Great deal. 30 cents, 20 cents on a dollar, let's buy it. I said, let me take a look at it. Well, I saw, and when I did the research, that the only way an ethanol plant is profitable is with a government subsidy. And the government subsidies at that time were being phased out. So if the government didn't give us a subsidy, there is no practical way, even if you spend 20 cents on a dollar to buy these plants, to make them profitable. So I advised against it, and that turned out to be, let's just say, very good advice. Applies that way to the healthcare system. If you let the government control your pricing, and it's not just Medicare, the federal government, the states control pricing through the insurance companies because every insurance company is regulated. When you're in that kind of a system, you're literally at the mercy of the regulator or the person setting your pricing, as opposed to the free market. And maybe that's why we have a lot of problems in our healthcare industry, because how the pricing is set, arbitrarily at times.
And artificially inflated gradually over time.
Yeah.
And the medical loss ratio right now is something that is perverse in what it's doing with, people wonder why the rates are going up. Well, it's because insurance companies don't have the incentives to lower their cost, but that's another story. Glenn Nadell on the show with me today. I recall discussing direct primary care with you some time ago. And so what are your thoughts about it as you've been looking at it, perhaps hearing about it? What do you see? I know it hits home with, a direct model.
Yeah, and I must give you a lot of credit for educating me. I had the pleasure of looking at a first draft of Hunter's book that he's been writing for a number of months, and I learned a tremendous amount. For example, back 30, 40 years ago, 70% of all doctor visits were with their primary care physician. 30% was specialists. Today it's flipped. 30% to the primary care, 70% to specialists. I also heard a wonderful story about Hunter, again, yourself, without going into details, how because he had a certain medical problem, thank God very minor, but it took his personal physician, because the Panama model is a VPC type model, to spend an hour or so with him in order to understand and then hit on something that I can tell you nobody else would have hit on, and it solved it immediately. And I know from my personal experience, I have a wonderful internist, been with him since 1990. He never rushes me. I always have an annual physical, always a year and a day after my last one, because that's when the insurance company will pay for it. And we go through all kinds of stuff. EMR is great. He responds very quickly on email. But I know if I could spend more time with him, he could delve even deeper if I had a medical problem. And let me, and I don't mean to go into socialized medicine, but I think this is a pretty interesting story. In about 1985, my wife and I went to Mexico, met a lovely couple, Canadian. He was a doc. So one night after dinner, we're talking, and, he's talking about how he makes his money and what happens. He says he works from 8 to 5, Monday through Friday. When he leaves at 5 o'clock, he doesn't hear about anything because other people kick in, etc. So he doesn't have any after hours. And he sees as many patients as he physically can. He doesn't take lunch during that 9-hour period. And I asked him why. He said, because that's the only way I can make the income that I want to. So one night after dinner, I happened to bring some sweets down to Mexico, and there's these chocolate fudge-covered Oreos that only come out at Christmas time. I gave him a couple. He loved them. So as soon as I get back to Chicago, I ship him 6 boxes. I get a call one day around noon in my office. I can't understand what the guy's saying. His mouth's full. I almost hung up on him. It's my friend, the doc. He was taking 30 seconds out of his day to say, thank you, I love the cookies, I can't talk now, I'm seeing patients, I'll call you on the weekend. Now, I don't mean to be critical of what kind of medical care he was giving, because he was just part of a system that was set up. And working within that system, the only way he could make a decent living was to see as many patients as possible. He didn't have the ability to do a DPC-type model to sit there and take his time and get a long and detailed history. It was almost what I'll call a Band-Aid approach. The guy came in with a cold, you either gave him some Flonase or you gave him whatever he needed, got him on his way, hopefully he was okay. But that system was the opposite of what DPC is, because it really rewards the kinds of volume that a physician can handle within a period of time. It doesn't reward the outcome of really sitting down. And again, I don't mean to criticize the Canadian system. It was a long time ago. Maybe it's different today. But I know that this particular guy, if he could get paid to sit down for an hour and delve into a patient and probably solve a lot of other problems, he would do it, because he was that kind of a person. Very caring, really wanted to do a good job, but he was in a system that rewarded quantity and not quality.
Yeah, it's funny, you do the research into time with the patient. Even in England, they're running out of time. They're complaining. The GPs over there, the general practitioners, family medicine doctors, internists, they're at about 10 and a half minutes for a consult, and they know it's not enough time. They're complaining about it, and they're running out. It's eating itself. That's the thing that most people don't recognize. And they hear the stories about how from the patient side, they walk out and they haven't paid anything, or they pay very little. But what they don't see is the other side of the doctors who are very frustrated, which kind of leads me to it's a great segue into my next little subject matter. And that is that we have this medical tsunami that's hit us, which is COVID-19, and it's battering the very core of healthcare right now. There was an article I just read about maybe 50,000 primary care physicians may lose their practices over this. They're not getting reimbursed. They have their offices, and they may just say, I'm done. And there's a lot of frustration out there with the doctors, and it's at all-time highs. It was already very high before this happened. And now I'm reading that many of them want out. And I hear that many are looking, but, and there's always a but, they're looking at non-compete clauses in their contracts, and that's a very big impediment for them. So they want to break free of the old system, and they feel like they can't do it. And I thought, well, but knowing the keen legal mind that I'll be speaking with, I'm definitely going to bring this up. And with the understanding that obviously doctors need to sit down with their attorneys, their own personal attorneys, to really sort things out. But I wanted to ask you what your thinking was about how doctors might break free from those non-competes. And if you had a client come to you about this, what would you tell them?
Well, I actually think, obviously every situation is different. I may have some very good news. First, every covenant not to compete is governed by state law. So each physician that either has a covenant not to compete or is going into a situation where they may request one, whatever state you're in, it will basically govern what you can and can't do. The good news is it's basically a three-tier system amongst the states currently. The tier one, which is the most favorable, states such as Colorado, Massachusetts, Delaware, and Rhode Island, there's a prohibition on covenant not to compete with physicians. If there is a covenant not to compete in your contract in any one of those what I call first-tier states, it's unenforceable. Shouldn't have been in there in the first place, but maybe it was there before the law changed. The second tier are states like Texas, New Mexico, and Connecticut, which the statute specifically describes the maximum scope and duration that a covenant can be for a physician. For example, the scope is geographic, 5 miles, 10 miles by county. The duration is 1 year or 2 years. So in those states, if you have something that exceeds what's in the statute, it's not enforceable. And Connecticut goes even further. They say that if you are terminated from your practice without cause is really a bad thing. It's the highest level of an act that somebody can do. It's basically fraud or theft. Then if you have a covenant not to compete in the state of Connecticut and you were terminated without cause, which could be the practice maybe wasn't making any money or any other of information, your covenant's not enforceable. The third tier are states that allow covenants for doctors, but even in those states or even in the second tier states, the trend today is clearly that courts, which have always loathed covenants not to compete in any business area, not just for physicians, and they hate to enforce them. But if you can demonstrate that by enforcing your covenant not to compete, there will either be a doctor shortage in the area that they're trying to enforce it, or alternatively, a specialty shortage, you have an excellent chance of getting that covenant overturned. Because the one thing that the courts don't want is because, as you've articulated, Hunter, there are doctors leaving the practice. So there are doctor shortages. So even if you have a covenant not to compete that technically would be otherwise enforceable in the third tier state or even a second tier state, but you can demonstrate to the judge or even to your opposing party, so you don't have to get to a court, that if they do enforce it, there's a shortage either in number or specialty, it's not going to be enforced. So the trend is clearly not to enforce or even have covenant not to compete with physicians. But again, I must direct you either to your local council or to your state because every state is different.
Sure. Well, it gives me two things there. It's the people, the doctors who they want to leave. They're quitting. And they're being forced to move, a long way away. And I've seen those complaints. There may be others that, obviously I don't see that are being expressed in private physician groups online, etc. But those are some very interesting ideas there. It kind of follows the art of fighting without fighting. I mean, I'm wondering if there's a strategy a physician could use in saying, look, this isn't working. The system just doesn't work for me, and I really want out. And we have, I guess, maybe some ideas on what you would suggest for that negotiating tactic to go, instead of fighting, how about not fighting and going in first with this is where I'm at. This is what I want to do.
Well, that's always the preferred course of action. My own view is litigation is a waste of time and a waste of money. The only people who win in litigation, and I can say this because I'm a lawyer, are lawyers. Lawyers always win in litigation. I mean, unless you take something on contingency, but that's the exception, not the rule. So while I'm sitting there working on a matter, I'm getting paid my per hour rate. Now, I certainly want to win, and I'm very aggressive, but by the same token, if I don't get the result that I hope to get, in theory, I still get paid. So it's always best in my mind to try and not have a litigation outcome. It just doesn't make any sense in many, many cases. So what I would suggest, if somebody does have a covenant that technically is enforceable, the first thing I would do is try and figure out a way that you can open up another practice, go with another practice, etc. Find out what your goal is, and then try and sit down with whoever's making the decision maker of the practice or the senior partner, etc., and talk with that person. Not bringing up the law unless the law is favorable. If you're in one of those states where, basically it's illegal, well, great. Or if you have one where the parameters are exceeded, yeah, I would use those immediately. But assuming you're in a state where they are enforceable, try and find some kind of lever that enables you to coexist with the other party. Because the one thing is, remember, putting yourself on the other side, like we started the conversation with, that physician doesn't want to pay $500 an hour to have some lawyer enforce a covenant, because it's going to cost him a lot of money. It's going to cost you a lot of money, too, to go after it if you have to. But that's why it's always reasonable to try and work something out privately. And if you can coexist, and the covenant was reasonable and otherwise could be enforced, try and play to the needs of the patients, because at the end of the day, patients, when they look at a practice, they look at their physician. So one of the reasons they have non-competes is if that physician walks across the street, most, if not all, those patients are going to follow him because they don't know the other three doctors in the practice. They only know Dr. Smith, who they've been going to for maybe 5, 10, 15 years. So that's why they have these covenants. But maybe you can work out something that, although it's within the 10-mile radius, it's, like by the 9th mile, again, something that you can work out, so it's really not going to impact them. You're not agreed to take any of their other patients, just the patients that went with you. There are a lot of ways you can kind of slice it depending upon the circumstances that are presented to you. For example, 10 miles in New York City, that's a pretty restrictive covenant because of the density of New York City. 10 miles in Wichita, Kansas, probably not that big of a deal. So it depends on where you are, what you're trying to accomplish, and also what your relationship was with the existing physicians and existing practice. If you can demonstrate them, or if I'm representing you, I can demonstrate that by doing this, you're going to leave anyway, so they're going to lose that revenue, but we're not going to take away any more revenue than the revenue that we otherwise generated. So from your perspective, why fight it? Because you're going to be in the same spot whether he leaves or stays, because if he does leave and you enforce the covenant and you can't find another physician to replace him, and that other physician then has to be able to attract the same patients that he did, who they don't have the loyalty to, you're not going anywhere. And also you can then point out, whenever you hire somebody new, there's always training time, there's always lead time, and maybe you make a mistake. If you make a mistake, and it's a bad mistake because she's not a very good physician, you're going to pay for that. So there's a lot of ways to slice it. It's almost what I tell clients, there's only one limit to how I would approach a situation like that, and that is the limit of my imagination based on the facts and circumstances I'm presented with.
Yeah. Glenn Nadell, legal mind extraordinaire. Thanks for joining me.
Thank you.
And to all of you at home right now, most of you are probably at home, stay healthy, wash your hands a lot, and there you are.